Good evening, everybody. My job is to make a practical approach to these cases. Before I start, I would like to quote what Dr. Ramarishnan put in today's API WhatsApp. He said, "Everyone knows it requires brains to live with diabetes, but to use insulin successfully requires more than brains." That's a very true statement, and it was very apt of him to put it today. So my topic today is to discuss Amit. Amit was the person we saw just now. That is the case presentation of my patient. Is uncontrolled on 3 oral anti-diabetic drugs. There is Amit. He just spoke to us. He's an accountant. He has an active life, and he has challenges in adhering to his diet. He's concerned about his lifestyle, which is very busy, as he's also worried about the impact of diabetes on his work, but he's a motivated individual. He wants us to advise him to bring his diabetes under control. So just look at his profile. His fasting blood sugar is 126. He has a postprandial of 226. HbA1c is at 10.2. Creatinine and other levels are fairly good. He was diagnosed 8 years ago. And please look at his history, the oral medications that he has. He has glimepiride 2 milligram twice a day, metformin 1000 milligram twice a day, and he has EMPA 10 milligrams. And as I said, I repeat, he's moderately adherent to diet and exercise. And the main thing is that dinner is his major meal. So again, my job is to simplify current complicated insulin therapy. Many of us know that we have to give insulin, but how to start and when to start, that is complicated. So we are looking at a story. It is a story of dogma, a story of therapeutic resignation. What did we learn? We have been learning that the cornerstone for type 1 diabetes treatment is the basal bolus insulin regime. It is a tedious regime. Patients get up to 4 to 5 doses of injection per day. And what is the gold standard for type 2 diabetes? Again, the basal bolus insulin. So we are going to see how we can simplify this. Now, Amit, if he comes to me, he's already on 3 oral anti-diabetic drugs. I will tell you why I want to start him on insulin, how I will target to treat, how I will initiate, titrate, and intensify his treatment. This is my approach. I'm sure many of you see such cases in your daily practice. So somebody who is uncontrolled on multiple oral anti-diabetic drugs. We have a group. That is the group which is on monotherapy. The group on monotherapy, only 33.06% is controlled on monotherapy. The remaining are not controlled on monotherapy. So we switch them on to dual therapy. When we switch them on to dual therapy, again, only 24.5% are controlled. So we switch them on to triple therapy. Then again, only 20.83% are controlled. So this man, Amit, on 3 oral anti-diabetic drugs, what am I to do, or what are we going to do further? If we add a 4th one, only 14.27% will be controlled. So what are we going to add? Our option will be an insulin. This is just repeating what Dr. Jayakumar told us. 8 out of 10 people have uncontrolled glycemia, and 2% higher average HbA1c levels, where the HbA1c level is considered 7. And insulin is initiated after 8 years, 8 to 8.5 years. That is what we saw in the case of Amit. Amit has been having diabetes for 8 years, and he has come to us now, and we are going to initiate him on insulin. So next, how important is it for us to manage both his fasting plasma glucose and his postprandial glucose in the Indian setting? So to make it simple, the HbA1c level is an addition of both the postprandial blood glucose and the fasting plasma glucose. Both have to be taken into consideration. It's not enough to take only the fasting plasma glucose or to take the postprandial glucose. We have to take both together. Basal insulin inadequacy, again I'm repeating it, 70% of the patients fail to achieve target even with basal insulin after 6 months. So starting a basal insulin is not solving our problem. So what is unaddressed in India? It is the postprandial glucose which is not addressed. 83% of the adults with type 2 diabetes in India have a suboptimal postprandial glucose. So this is leading to suboptimal control of diabetes in India. So what is the message from this? Targeting of the fasting plasma glucose is not enough. We cannot achieve a long-term HbA1c target level by targeting the fasting plasma glucose alone. So the ground reality in India, again, I'm repeating what Dr. Jaykumar said, 9 out of the 10 healthcare workers preferred an insulin therapy which will control both the fasting and the postprandial blood sugars. So we want to simplify the therapy. We want an insulin which will address both the fasting and the postprandial blood sugar. Now, when we said this, now the next question is, what is the ideal time to initiate insulin? How many oral anti-diabetic drugs do you add before considering insulin therapy? So this we already discussed. We said, I told you with 2. We get only with 2 oral anti-diabetic drugs, we get only a reduction of 1% HbA1c. If we add a third one, we get a reduction only of 0.5%. But if we add another one, instead of the HbA1c coming down, it increases by 0.2%. So if you are already on 3 drugs, adding a 4th one is not making sense. Then suppose we add insulin to the 3 drugs, then the HbA1c drops by 1.3%. So successive oral antidiabetic, adding an oral antidiabetic drug will only provide lessening effect. And to get more effect, we have to add or initiate insulin. So what is the RSSDI 2022 recommendation? Insulin therapy should be considered in all patients failing to achieve the target on 3 oral drugs. However, additional drugs may be considered if the HbA1c is just 1% or 1.5% above the mark. Clinicians must consider the limitation of individual oral drugs or their combinations in terms of the quantum of HbA1c reduction. So consider initiating insulin in type 2 patients with severe symptomatic hyperglycemia. Don't wait till you reach 3 drugs. If the person is having severe symptomatic hyperglycemia, the insulin can be initiated even earlier. So we have a 3-step protocol. That 3 steps, you initiate the insulin, you titrate the insulin, and you intensify. This is what we do for all patients. Initiation. When you initiate an insulin, you have a problem. The problem is that your patient is frightened. They don't want to take insulin. They would rather have a fourth drug. So patient education will be very important. Providers should not use it as a threat. They should not describe it as a personal failure or punishment. You should try and tell them to get over their anxiety. You should talk to them about hypoglycemia, dependence, injection site pain. These are the things which keep worrying them. So you have to do a good patient education. And you can discuss with them the therapeutic choice of the regime. What are we going to do? How are we going to give it? The preparation, the delivery device, all this should be discussed and an informed consent should be taken. Now, how do you choose an insulin regime? Based on the fasting plasma glucose and the postprandial glucose level. So let's look at this. This is the aid for insulin decision. Look at the postprandial glucose excursion. If that postprandial glucose excursion is more than 74 milligram percent, then the insulin, your first choice of insulin to be added is a rapid-acting insulin. The second choice is a pre-mixed insulin, 50:50. Suppose the postprandial glucose excursion is 40 to 74, then the first choice is a pre-mixed insulin, 30 to 70, and the second choice is a pre-mixed insulin. Now, if the excursion is below 40, a basal insulin is the first choice. So how do you reach, I'm just saying 74%. So how, and then saying 40 to 74%. How do we reach this value? You take it by calculating the postprandial, you take it by calculating the cutoff values of the diabetes, 200 and 126, fasting at 126 and postprandial. So 200 minus 126 is 74. That is how we reach the mark 74. So this will be your baseline for all the patients you're going to treat. So Amit, what are we going to do to Amit? His fasting was 126 and his postprandial blood sugar is 226. So what is the glucose excursion in his rate? I think it is somewhere approximately 100. So if it is 100, the excursion is between 40 to 74 milligram. So my choice should be a pre-mixed insulin, 30/70, that should be the first choice. And the second choice can be a pre-mixed insulin, 50/50. More than? Yeah, sorry. Please, I'm sorry. More than 7,400. So the first choice is a rapid-acting insulin, and the second choice is a pre-mixed insulin. I'll come back to that. Now, I said we are going to give him an insulin, and then we talked about which insulin we are going to give him. And here, the reason I mixed up the pre-mixed insulin, I will come to that, and the rapid-acting insulin is, the rapid-acting, if you look at his profile, I'll come to that later. It is safe to start, so how will we start this insulin? You can start it at 10 units daily. So, or you can calculate at a low dose of 0.15 units per kg per day and normalize the fasting plasma glucose with a long-acting basal insulin. So if you are starting a basal insulin, which I did not discuss here, then the dose is 10 units, or it is 0.15 units per kg per day. And then what do we do? I'm talking of basal insulins. We should titrate the dose 2 units at a time every 2 to 3 days until the fasting plasma glucose is at goal. If you want a more aggressive approach for the HbA1c is very high, you can use 0.3 units per kg. I'm talking about the basal insulins. The treat to target concept use titration schedules based on specific algorithms, starting with 10 units once daily and unit adjustments. This is assuming a patient is 60 kilograms and we are giving him 0.15 units per kg. So basal insulin, but I talked about basal insulin and the doses, but nowhere did I say that Amit is going to get a basal insulin. He's getting a premixed insulin. So what are we going to give him? And how are we going to titrate that? One injection of premixed insulin with the evening meal can be started at doses similar to the basal insulin. So when we write the premixed insulin, the dose calculation is also 0.15 or 10 units. It should be titrated based on the bedtime as well as the fasting plasma glucose. So for the titration, that is what we are going to. So, and suppose we are not able to achieve a good control, we have to give bolus doses of prandial insulin at meal times. And you can titrate that depending on the 2-hour postprandial or the next pre-meal blood glucose sugars. Now, Amit, we said the excursion is more than 100, and we are going to give him a premixed insulin. So first time I'm going to calculate it at 0.15, assuming they have only given his BMI, assuming his weight is 60, we will give him 10 units, and with the major meal. So his major meal is at night. So we are going to give it at night. And we are going to continue all the oral hypoglycemic drugs, the 3 drugs he was taking. And how are we going to try it, titrate it? We are going to titrate it by wait every 2 to 3 days, and then increase by 2 units. Now, why did I leave out the short-acting insulin? If I am a bit frightened. If I am to give him a short-acting insulin at meal time, dinner, with 236 blood sugar, then I will be giving him 10 units of a rapid-acting insulin. So the danger of a hypoglycemia. So my first choice would be a premixed insulin. I hope I've made myself correct. The recommendation is to give a short-acting for an excursion above 74. But a short-acting or a rapid-acting insulin at 10 units with a blood sugar of 236, I'm not very sure whether he will go into an hypo. But if I give him a premixed insulin, which is 50-50, 50 of the rapid-acting will act immediately, and the other will be a basal one acting slowly. So that is why I thought a premix should be the first one. So if you want to give the patient 2 times, you can also start it at 10 units with the morning and the evening meal. A larger dose can be given with larger meals. It is imperative that you use correction doses to achieve your HbA1c goal levels for titrating your premix insulin. So 2 to 3 days, you can add 2 units, 2 units, 2 units, and you titrate it. If you want to titrate the morning one fasting, you increase the evening dose. If you want to control the evening postprandial sugar, then adjust the morning insulins. So incorrectly increasing the dose of insulin at the same time that the blood sugar is high, that can cause hypoglycemia. So that is why we have to go step by step. We cannot rush. We have 2 choices, either a rapid acting or we have the premix insulin. The algorithm says for a person like Amit to put him on a short acting, rapid acting. But I would prefer the second one because of the fear of hypoglycemia. So thank you very much for your patient listening.
Thank you very much, Dr. Geeta. I hope Amit will be happy and his blood sugar gets controlled and with a better A1C. Now let us see what Dr. Deepu has to do with Kishore and Lakshmi. So over to you.
Thank you, Dr. Geeta, for starting off the talk. In fact, it's a real honor to be back at API. It feels like presenting in front of your own school or college. Dr. Geeta actually stole my first slide thunder by taking Dr. Ramakrishnan's quote in the WhatsApp group. So I will go one up. In fact, this is reminding me of a time when I had to give my first talk in API as a speaker, and Geeta Madam was the API president. And that time I was at St. Joseph's Hospital, Manjamal, and I had to make my own slides for newer antibiotics in practice. This is 14 years back, if I'm right. So thank you API, and thank you Novo. So I'll get going, otherwise poor Tom is already asleep from all the slides. Okay, so I'm going to look at the second case, which is patients who are uncontrolled on glargine. Since Novo has given us a beautiful video summarizing the case, I'm not going to go through that again. Lakshmi, as you made out from the video beautifully, is a female 55-year-old homemaker who's having the challenge of managing her household, obviously all 3 of her kids, including 2 children and her husband, and she is concerned about postprandial sugars, and she is missing yoga classes, which is probably her way of de-stressing also, that I can make out. I'll concentrate on her reports because the rest of the story Lakshmi herself has told us through the video. So if you look at the values, her fasting is fairly okay, 132, and her postprandial is 300. And if you remember from the video, she is really worried about the postprandial excursion. Her A1C is around 9.2. Creatinine is 0.9, her LDL is around 96, fairly okay BMI for a housewife, 27.3. And look at her medical history. She's on sitagliptin 100, she's on metformin 1000 twice daily, she's on dapagliflozin 10, rosuvastatin 10, vitamin B complex, probably somebody has tried to correct the lethargy with some B complex, and she's on glargine 20. See, this is probably the new challenge that a lot of you as senior physicians will be facing henceforth. It's like the new metformin that I call. So when patients come and tell us that they're on insulin, always check what they're on. Earlier they used to say, ഞാൻ ടാബ്ലറ്റ് കഴിക്കുന്നുണ്ട് ഡോക്ടറെ, റെഗുലറായിട്ട് കഴിക്കുന്നുണ്ട്. We always knew it was only metformin. Now the latest challenge is, I'm taking insulin every day regularly, doctor, then you should always check whether it is glargine. So lately, her complaint is what we will get to. As Soni was telling, it's an individualized therapy that we are looking at. So lately, my diabetes is affecting not only me, but my family as well. And I'm always feeling exhausted, and I miss my yoga classes frequently. So she has an insight. She's realized that she has got a problem to fix. So considering this scenario, do you think basal insulins are adequate in the Indian context? I'm not going to go through these same slides, because basal insulin, as eminently clarified by Professor Jayakumar, shows us that 70% of our patients fail to achieve a target within 6 months of initiation with the basal. And 75% of our patients fail to achieve it even at 1 year when initiated with a basal insulin. And that is basically because, as Sir and Madam clarified earlier, postprandial glucose excursions is what is causing all these uncontrolled A1Cs as such. So how do you see this impact of postprandial glucose? The same slide which was shown by Jayamar sir shows that the excursion is mainly happening with the postprandial glucose control that is leading to uncontrolled A1Cs as such. Now, PPG has, postprandial glucose has, as lucidly elucidated by the 2 earlier speakers, stronger correlation with A1C than the fasting, and it has a much more sensitive specific role than what we usually get with our fasting blood glucose. Like Jayamar sir was telling, if you are actually in a very busy clinical practice, you have to actually tell the patient that fasting is not enough. And Anish was just telling me that if your patient actually keeps coming back with fasting, you have to tell him that I need the other sugar also to be checked. So what are the reasons for the high postprandial glucose? It is obviously because of the high percentage of carbohydrates that's there in each of these plates. So if you ask any of your appachans and ammachis, they will tell you that I haven't had anything for dinner. Then you ask them, what did you have? They will still tell you that they had some fish, they had some salad, but chore undillillo doctor. Okay, so before you all go hypoglycemic with your own appetite rising, remember 50% of the day for most Indians is spent in postprandial phase, and those of us are consuming a heavy 3 meals. That's the minimum that most of us are used to taking. An Indian scenario is far worse because of the high carbohydrate diet, and we have seen all across the plates of whether it's a South Indian, North Indian, or an Northeastern India, we have seen that the carbs contribute the predominant part of a plate. So for an identical carbohydrate load, most of us South Asians also exhibit a postprandial glucose peak that are around 2 to 3 times larger than the Caucasians. Asians have also shown a decreased insulin secretion capacity, which makes things worse, and the unaddressed postprandial glucose excursions are also leading to significantly worse diabetic control. That's exactly why Dr. Jayakumar set the context, saying that 83% of the adults with type 2 diabetes have suboptimal postprandial glucose control. So it's for all of us here as serious practitioners to look at postprandial glucose excursion as the next challenge ahead of us and try and look at controlling that better. How do you get about doing that? Obviously, look at the diet of the patients, see what constitutes the plate of a patient. Recently, I was going through the IMA official page, and Dr. Srijit was trying to tell us how the plate should look and things like that. Those are proactive ways in which you can actually converse with your patients on social media. So how could you manage the case scenario? So obviously, we will obviously have to put her on insulin, which will control her postprandial glucoses better. You will obviously, as elucidated earlier by the two speakers, you can actually think of a co-formulation or a premix insulin twice daily. And if she is somebody who's used to taking insulin once daily, that's the biggest advantage of a basal, So the fear of hypoglycemias, which was always the limiting factor for most of our patients. So if you actually ask your patients, there are only two major concerns when you tell them about insulin. One is, will I have hypoglycemia? Two is, does it have to be lifelong? These are the major questions that your patients always have on the mind. So if she is somebody who is used to a once daily insulin and she insists on a once daily insulin, probably because she is not on a secretagogue, you can still get along with the co-formulation. But if she is somebody who actually is open to an adjustment of a premix insulin, considering the budget constraints of a homemaker, I would still offer her a premix twice daily also. Now, coming to the third scenario of this particular subset, we have Kishore, a beautiful gentleman aging gracefully, who is actually in his jogging tracks, and he is actually extremely alarmed about imperceptible hypoglycemias. He probably has had nightmares, he's probably had night sweats, he's probably had nocturnal enuresis, you name it, they've had all sort of weird presentations about hypoglycemia. Hypoglycemia is an expensive thing also. So if you get a call saying that one of your patients has come to the casualty with a hypoglycemia, I dare how many of you would say shift him to the ward? Overnight, most of our patients actually go into an ICU. That itself sets you back by 10,000, 15,000 rupees. So it is an expensive proposition. Forget the mental aspects of being in an ICU and the trauma that an elderly man goes through. This man, if we actually just go through his medical history, his fasting is 118, his postprandial is 230, his A1C is 8.2. So somewhere he is having even hyperglycemias to compensate for all the hypos. And his medications, there itself lies the culprits. He's got glimepiride 1 milligram twice daily, he's on sitagliptin 100, metformin 1000 twice daily, atorvastatin 10, telmisartan 40, and he's on glargine 30 units. So his worry, in his own words, his story is low blood glucose at night is always on my mind, and I'm fearful of such episodes impacting my life as such. So how different is an elderly when you compare it with people who live with diabetes? How different are they? The concern is predominantly if you have taken care of geriatric patients, or as I often say, we have to take care of geriatric patients because that's the future of Kerala medicine anyway. Asymptomatic in often 50% of our older patients, there is osmotic symptoms are less prominent. There is reduced intensity of the polyuria and polydipsia that you usually see with diabetes. Most of them are non-specific, with fatigue and lethargy being often mistakenly attributed to just age catching up. There is neuropathy, visual loss, and the biggest worry among most of our elderly patients, falls. So you're worried about the falls that could be precipitated by hypoglycemia. So need for a different approach is very important because you will have multiple concomitant geriatric syndromes ranging from social isolation, community dependent caretakers taking care of them. There's a functional heterogeneity also. People have varying levels of comprehension with regards to how you address them or tell them about their medications. Obviously, there are also going to have varying expectations of self-management with aging and increasing frailty. Now, it is not different from the data that we studied earlier from the slides saying that diabetes is definitely rampant in South India, and it is one of the most widespread human health burdens, especially in the elderly. And I'm not going to read you through the slides. 12% of your patients over to 65 with type 2 diabetes have an evidence of islet cell autoantibodies, which may be associated with the risk of severe hypoglycemias also. What about diabetes and aging? There is obviously an interlink, which is because of increased risk of sarcopenia. Now that is where the increased likelihood of frailty and falls and the increased risk of incident depression is also noted with 27%. Often this yo-yoing between hyper and hypoglycemia also increases the risk of cognitive dysfunction and dementia by at least twofold. And often the mental and cognitive disabilities of these patients are graded as dementia, depression in varying terms with increased risk of diabetic complications setting in. Now, how do you take care of these issues? Often it is disturbing because most of them are in assisted living, sons or daughters taking care of them, and you have to check their ability to administer insulin by self and check if they can take care of self-monitoring of blood glucose at home. Now, the fear of hypoglycemia, you have to accept, is a genuinely big concern for most of our elderly, and it obviously affects the diabetes management, and you have to take the patient into confidence because you have to also look at the quality of their life, often the emotional well-being of somebody who's been through the trauma of going through hypoglycemia. Kishore himself has told that he's got admitted to hospitals. So you have to reduce the engagement. It is often because of the reduced engagement with the diabetic management team. And many a times I often tell in my talks that you have to actually employ a diabetes educator who might not be a trained personal as such, somebody who's a passionate nurse or a helper who is keen to learn about diabetic management, who can spend much more quality time with your patients. And all of these lead to impaired diabetes outcomes because they tend to prevent a hypoglycemia by underdosing, and often they think the only culprit is insulin. When most of the times, like in this patient, I'm sure you would have noticed that there's a heavy dose of sulfonylurea also going on. So what do the newer generation of insulins which are in the market now have to offer? Now, basically, as ma'am was trying to say, you have flexible dosing that's available. Like she was trying to tell you that you would probably time it with the biggest meal that the patient usually takes. There is a convenience of administration post-meal, which is important for elderly. There is a lower risk of hypoglycemias, which is obviously with the analogs. There is a faster onset and offset, and there is less number of injection pricks, especially with the new co-formulations. You are guaranteed of a improved quality of life, and there is more predictable effects on these patients. So often when you look back at this patient, you can still probably look at co-formulations as the ideal drug for all these three situations, whether it was Amit that Dr. Geeta was trying to tell us about, or Mrs. Lakshmi who was uncontrolled on glargine, and Mr. Kishore who had the biggest fear of hypoglycemias in the elderly. So I'm sure Tom will talk us through the rest of the slides. Idagaspart as a co-formulation in these clinical situations, which are very, very archetypical of what we usually face. The solution probably lies in a co-formulation. Thank you for the patient listening, and I hope to take the questions at the end of Tom's talk. Thank you.
Thank you very much, Dr. Deepu. Thank you, Dr. Geeta. So we'll close the session and hand over the thing to Dr. Prasanna Kumar, who will chair the next one. Thank you.
So now we have come to the last session of today, that is redefining diabetes care with IDEC ASP. We know most of our colleagues sitting here has used this formulation on and in and out, on and off very frequently. We know it has got better glycemic control as well as comparatively less hypoglycemic episodes. To explain more on this, now I invite Dr. Tom Babu, endocrinologist, Silverline Hospital. Dr. Tom Babu, please be on the dais.
Thank you, API. Thank you, Noah Nordisk. So the cases we've been talking about are fictitious cases, but powerful cases nevertheless. But I want to start because I noticed that most of the slides are what I also am going to show. So we'll deviate there a bit. And let me turn your attention to two of my cases that I've seen in the last, one case we have with us in the hospital. So this is like a 55, maybe a little older than me, lady, or young, I think my age. So she's employed, and the truth is, every time she comes and goes out of my OPD, though I am all smiles in front of her, I feel like going and banging my head somewhere and telling her not to come back to me, because she just drains me out. Because this lady, for the life of her, would never do what she's told. She's on most of the drugs that you can imagine, and insulins as well. But the problem with her is that she has this fear of hypoglycemia, and every time she comes to my OP, her blood sugars are 500, 550, and she has a lot of social issues in tow. She's always blaming her husband, and she gave me a picture that her husband is like a tantalizing person. And today morning, I met somebody in her room. It looked like a very meek guy. And I was thinking, is this the person she described to me? And I'm thinking, like, now who has the problem just now? Anyways, so how frightful hypoglycemia can be, I can only try and empathize with her. And so the physician, so usually how it happens in Silver Line is we admit, and the physicians will take over. And then we'll finally, when everything is done, we'll see, and like that. So our physicians were having a rough time with this lady, because I've been treating her for the last, as far as I can remember. And but they don't know the emotional stuff that's going through her mind, and how this hypoglycemia part is haunting her. But maybe such people have other issues too. It's just not the hypoglycemia, just that they all come together for these people, I suppose. Or I don't know, it could be more complex. Anyways, so that's one story. Second is another 86-year-old charismatic lady who I've been treating for, I don't know, again, for a long time. And I like to see her, because she comes, even at this age, she comes decked with her diamonds, and I'm the one looking at her. I enjoy looking at those diamonds. I always compliment her. And I think she always makes it a point to wear a new set every time she comes. And but I keep thinking about her, meaning that because my biology teacher in school is in some way connected to her. So when I think about, I see him on my teacher in Facebook posts. So I think about her. So I'm thinking 86, because I hadn't seen her for a long time. I thought lost to follow up, or must be dead and gone, like that. So 2 days ago, the daughter brought her to my OPD, and lo and behold, looking as charming as always, another set of diamonds. And then she gave me a poke. She said, "Hey, doctor, you're looking very prosperous. What is it?" And everything and all that. But the story with her is that I had trouble because she rolls off her bed. She's staying alone, children in some Johannesburg, some all over the place. She's got 2 or 3 kids, nobody here, typical home nurse taking care. And so every now and then she rolls over her bed, she falls down, then the children call me from wherever, but I'm obliged to answer because I know them personally. So I'm like, what do I do? I mean, blood sugars, again, 400, 500 all the time. So now, right now, you know, it was music to my ears that she saw me, I think, like 6 months, 8 months ago. No problem since. And the only problem she has is she says, "Doctor, I like to have a Sprite every day. Is that a problem?" So I'm just hoping that it's just a Sprite and nothing else in it, because then that explains why she's probably rolling off. Anyways, just a case in the point that hypoglycemia can be a big problem. So insulins, whenever we speak about insulins, it comes with a sting in its tail or a stick attached to it. So therefore, how do we navigate this conundrum is what I'm going to skip all this, like I said, repetition. Yeah, so this is an interesting slide here, which says that 90% of our healthcare providers prefer a premix insulin to a basal insulin. And I certainly, from my practice, you can have your own views, but ever since a co-formulation, not even a premixed, but a co-formulation, which we'll just be delving into a little bit. A lot of you are already familiar with it, but still. So ever since a co-formulation came, I don't use just a basal anymore. I use a co-formulation because, as the slide says, 90% of us believe that just a basal won't do it. Call it our South Asian descent, call it South Asians come with our unique dietary habits, call it whatever, but still, I think a co-formulation has changed the way I practice. But I'm not here to say that co-formulation is the only thing that, or it's panacea, it's going to solve all our problems. Not really. We all know that we have to pick and choose from this smorgasbord of options that we have. So, but still, it's important to understand why is this lady, this 86-year-old charismatic lady, getting younger, at least happy to keep her alive, or this other lady in our hospital who's, I think I've given her the confidence that it's okay, we have better, we can avoid it, and really her FGMs are well controlled today. And I told you, I met this husband who was otherwise like a very meek dove, just contrary to what I believed. Anyways, so I think one of the things here is that a co-formulation where you have like a fast-acting insulin with a long-acting insulin, both packed together, but at the same time acts separately. So this is, to a large extent, changed my practice. Not going into the technical part of it, and this is why the RSSDI have pointed in favor of premix insulins, and they've also gone on a limb and said that co-formulation, whenever you have hypoglycemia as a problem, whenever you need flexibility, whenever you need a more simpler regimen, less number of pokes, you can think of a co-formulation. So basically, these cases, as fictitious as it may be, but what we need to understand is that there are 3 landmark studies, which I'll just go through briefly. So now, what happened with Amit is that now you need to decide on which insulin, right? So what are the options in front of us? We have like a glargine, what we used to think as basal, and now you have a co-formulation where you have a aspartame degludec, which is a basal but On top of that, you have a fast-acting insulin. So the Onishi et al. Study, so this study, you would have figured Onishi, Japanese name, right? So this study was done in Japan. Was one of those landmark trials for the co-formulation Ryzodeg. It was a 26-week trial where they compared glargine with a IDEG-ASP, means it has aspart and degludec. So right there, it's unfair. Why? Because on one side you just have a long-acting insulin, on the other side you have they cleverly managed to put this together, but you're comparing to, for me personally, I feel it's an unfair comparison, but still, obviously, it will show its pedigree because you have a co-formulation. And what you see here is that you see that the Ryzodeg fared much better in terms of the A1C, but it's just not that. How did that happen? Wait a minute, sorry, I did go back. Yeah. So you see, Ryzodeg in the West, and generally as a label, what they tell us is to give it pre-dinner, or give it with the largest meal. But generally, most of these studies were done pre-dinner. So you can see what happens after dinner. You give this shot of co-formulation, IDEG-ASP. You can see that blue line there. You see the IDEG-ASP group did almost 50 milligrams better, right, post-dinner. But when you come to the fasting, it kind of leveled off. So the whatever A1C advantage, so between the glargine and the IDEG-ASP, the Ryzodeg, you had something like a 0.2% improvement in A1C, and the improvement came post-meal. Expected, because the aspart is what did it for the study, and that's where the advantage came. So obviously not a fair comparison, but still it's there for all of us to see. So better insulin for sure, but no hypoglycemia. Even though you get that push, you get that improvement, no hypoglycemia. And yeah, so this is in this context, if you compare IDEG-ASP, a co-formulation, and a basal insulin means otherwise glargine as we know it. This is a meta-analysis looking at a few studies, and Onishi is one of them, and you can see that it all favors the co-formulation, meaning the nocturnal hypoglycemia, right? So that's the lesson we learn from this study and that case also. So the advantage here is that you can actually give this. So just imagine, like for example, the lady I told you, home nurse, Pepsi, Sprite, this, that, and the other. So the advantage is even if the home nurse comes a little bit late, or for some reason called in sick, came in the evening, so the morning dose can be given at night. So that's how flexible it is, like that. And this is why, if you look at the label, you can administer Ryzodeg with almost any meal. Whereas a glargine, you're kind of tied around the insulin, because either you give it at the same time, that is the U100, or the U300. It is said that either 3 hours before or after the usual time of insulin. And so we'll skip this. Lakshmi's case, now what are we trying to see here? So why was this case put? To tell us about this switch study. Now what happened in switch study, otherwise called the CREATE study, again one of those studies done with Ryzodeg. So what they did was they took almost anybody, basal insulin, premixed, orals, anything, and they switched off everything and switched to Ryzodeg. And what did they find? They found that Ryzodeg, on top of everything else, gave an additional, for example, overall it was something like close to a 1% reduction. But people on basal, that is glargine especially, when you stopped and switched over to Ryzodeg, you got almost 1%. So across 1.6% additional improvement. So I reckon that how this improvement, well, it is like any other basal insulin, like any other rapid acting insulin comes together, and all that is there. But I reckon that it's from the stability of the insulin that you don't have the hypo, hyper, and that's where perhaps you get that consistent. I mean, that's the only explanation I can come up with, because otherwise, after all, it is a long-acting insulin, like glargine, like anything else. So perhaps that's my thought on this. So so basically they're talking about diabetes treatment, quality of life score, which was much better, and so forth. So perhaps true. So this is the one that I'm talking about. So the quality of life scores improved with Ryzodeg in the study. And lastly, our friend Kishore, what are they trying to say in the study? So where they looked at somebody on glargine, shifted to Ryzodeg, and you could see how frightful he was about hypoglycemia. And when Kishore was shifted to a Ryzodeg, you can see his A1C is improved, and at the same time he did not have hypoglycemia. And if you refer back to the Onishi study, where you saw that even though it was a better insulin, no hypoglycemia. So, and I think I pretty much stop here. Elderly population we covered, and I illustrated a case to you as to why it can be more safe. And then in some special populations like Ramadan, just around the corner, elderly, elderly, hepatic, renal, all these things, it's approved and it's safe to use. And I think I'll stop here. So this was summarized for you earlier. Thank you.
Thank you, Dr. Babu, for the excellent presentation of the case. And for our discussion, I invite all the speakers to be on the dais. I invite Dr. Geeta Philip, Dr. Deepu George, I invite Dr. Soni, Chairperson.
Anyone has anything to add on, or some of your personal experience, or some special cases where you had some special opportunities to handle cases? Please come forward, senior persons. Any doubts also could be cleared.
All the speakers for an excellent presentation. I was just thinking about Amit. Amit was very active, he was a little hyperactive. In fact, hemoglobin A1C was 10.2. His postprandial was 230 something. And his main meal was dinner, So I think probably that is the one thing we have to tackle, his dinner. Probably he should be asked to take lunch or breakfast as the main meal, because that itself will correct his hypoglycemic problem. So all these people had a postprandial hyperglycemia. So that shows either the drug is not acting or the meal is more harmful. So I think that is one of the things which was observed. We have been always telling about the postprandial, not the fasting. So there was something related to the food and what is called the calories and glycemic index, but the type of the food they are taking. all these people have a BMI more than 27. So I think BMI, their diet, their dietary pattern, all will need to be corrected. Of course, finally they may have to take insulin because about 10 to 12 years of diabetes on medication, and that I think the girl was Lakshmi, I think Lakshmi was not on any insulin or GOX. She was not on any insulin or GOX. So I think she was only on metformin and sitagliptin and this one. I think that was to be added, I think. That's all my comments.
About the diet, he said that he is fairly adherent to the diet. So we are assuming that he has been educated on the diet. Of course, for any diabetic treatment, I think the first thing is patient education, the meal. And in the Indian scenario, I think what we are trying to bring out is that the postprandial blood sugars are the highest compared to the Western people. That is why, and the carbohydrate content is more. Then in Lakshmi's case, I would like to think adding a fourth one, whether it is an insulin secretagogue or otherwise whatever, would not reduce the HbA1c. Because one of the slides we showed that after the fourth one, it will reduce, but not, it will increase. In fact, that was what it showed. So after 3, whatever oral anti-diabetic drug you add, it may not reduce. You could add a fourth one if the HbA1c is only very minimally elevated.
Plus, I think just to clarify on your sulfonylurea for Lakshmi, see, it's not very easy to continue sulfonylurea with even a basal. I'm sure Tom and ma'am will agree with that. And probably it's not the ideal drug for a lady who's on the higher side of a BMI also. I agree with you that probably it should have been there as a second drug. But definitely I wouldn't add a sulfonylurea as the fourth drug. That's my take on it. I would like to know what Tom thinks about this. No, but how much do you expect the A1Cs to come down with the sulfonylurea? I think that's not a wait and watch approach that many people will have an evidence base for. 55 years, so many years of diabetes, HbA1c is more than 9. I don't think it's a realistic expectation to add on a sulfonylurea and then cut off. What will you cut off? You'll cut off a gliflozin or a gliptin, which I don't think is right now. I don't think the evidence base is enough to take off any of those 3 drugs. No, that's what I said, sir. It probably, we don't know the previous prescription of that patient before the glargine was initiated.
Whether it was stopped?
Yeah, it was stopped when probably the basal was started. That's what I assume.
So
when you see,
I was just thinking that while it's cathartic to talk about diet and the importance, and we wish that they ate better for dinner and everything. But in real life, what happens is, if you try telling a patient that, please go and meet our nutritionist and take her advice, it's so hard. You'll have to literally pull them, push them into the room, because they say, we know all these things. What is that? What are you going to tell us about it? Nobody wants to listen to this. And the tragedy is that we have a fantastic nutritionist with us, and I wish that most of my patients, or at least the ones who do not or need to meet a nutritionist, need to. But 9 out of the 10 times, they just will not go. They don't want to. And the general premise is that I know everything. What's there? You don't have to teach me about it. So now, but what works is people with obesity, people who, that kind of a thing, then they're ready. Okay, 9 out of 10 would go me, because they think that there is something at the end of it, they get something out of the end of it. So I've given up on this part that, like we were saying, you just have to pick and choose. Just understand that this is how it will be, and reconcile with that. It is very humbling, but at the same time practical, and find your way around it. I mean, if you have to, SU, insulin, DPP4, SGLT2, whatever works, you'll just have to figure that out. But the last thing our patients would do is try and, sit patiently and listen to what a nutritionist would have to say.
Just for the sake of argument, Amit is an active individual. So most probably he's an IT worker. So he's unable to have his major meal at lunch. So his major meal may be dinner. He could not change that. So that is the advantage of having something like Rysodec, which will be flexible dose. So even let's look at a doctor, surgeon. If we ask him to take a large meal lunchtime, I don't know how he's going to make it. So if he doesn't make it, then his big meal is going to be the dinner. From Amit's picture, I am picturing an IT fellow who's very active. He's unable to keep proper timing. So coming home, that will be the major meal. If that is the major meal, then we have to address that. Of course, we have to educate him. And Rysodec perhaps plays a role there because of the flexibility.
I think the cases were very fictitious, as Dr. Tom was saying. Had this been the patient, what's your take on? Most of the patients were obese and the BMI was high. So again, insulin or any other options, forget about the insulin part of it, GLP-1 or something like that, for that lady who has been obese with BMI high. What do you think about that?
Certainly, GLP-1s are, it's hard to give, since we're talking about insulins, we are kind of compelled to stay within the scope, but still, I feel GLP-1s definitely are, making a big inroad into the way we treat, with the prices coming down, you have those means combined long-acting with GLP-1 along, and, for 4,000 rupees a month. So all that's looking very attractive, certainly.
But in these cases, other than insulin, considering their BMI and all, we can also think of a small dose of pioglitazone in some cases, not all. So especially if the BMI is high, definitely we have to be more careful. Otherwise, we can add a small dose of pioglitazone. It gives better control. That's what I want to know the opinion about the speakers.
So whenever we think that there is utility of pioglitazone, we don't shy away. We give pioglitazone, but on a wing and a prayer that, they don't gain weight, we're not going to worsen heart failure, or if there is some incipient heart failure and stuff like that, we may be precipitating something, so we'll have to be a little bit cautious. But as Dr. Prasanna was saying, wherever indicated, and when we don't have another option, that's when we tend to use pioglitazone. But it's an effective drug, useful. It's going to remain with us for some time.